Hello, everybody. Welcome to ColonCheck webinar today for ColonCheck recommendations for average and increased risk populations. Before we get started, I just wanted to ask if everyone could mute your line. It's Command M on your keyboard or Control M if you're on a PC. If you have questions, we invite you to type them into the chat box, which will be on the right side of the screen. So you can just type those in and we'll address those as we go. And we are going to be recording this webinar and posting it on our website. So we're going to get started. Dr. Ross Stimson is going to be the first speaker.
Hi, Ross Stimson here. Thank you very much for coming. I'm the medical lead for ColonCheck Manitoba, which is the provincial screening program. I'm here today with Leslie Baldry, our health educator, and we're going to go over some different issues related to screening. In particular, we're going to focus on the use of FOBT testing and come up later on with some recommendations in regards to screening and surveillance. I hope you can all hear me properly. So these are the objectives for today. We're going to look at the evidence surrounding the use of fecal occult blood tests and other strategies for colorectal cancer screening. I want to compare some of the results with screening with a Guaiac FOBT, which is what we presently use now at ColonCheck, with some of the newer immunochemical FIT testing. And some of the FIT testing is being done on an ad hoc basis here in Manitoba by various primary care providers. It, however, is not part of the program at this present time. We're going to discuss the future potential uses of FIT for high-risk screening and surveillance, something which is now becoming a popular idea that perhaps FIT might be able to replace colonoscopy in some areas where it's traditionally been used. Then we're going to look at the current guidelines for average and above risk screening and surveillance and review the current ColonCheck Manitoba operations and talk about our program and the supports for colorectal cancer screening. So just a few quick things about colorectal cancer. This is the third commonest cancer in men and women, men behind lung and prostate, and women behind lung and breast. Overall, there's a very high risk of developing colorectal cancer. Overall, it's 1 in 14 to 1 in 15 individuals. So it's really a truly serious public health problem. And unfortunately, it results in 13% of the cancer deaths. It's the second commonest cause of cancer death. So colorectal cancer is actually one of the most ideal diseases to screen, and this relates to the fact that it has a fairly long latent period of up to 10 years. It takes approximately 10 years in order for a polyp or an adenoma, okay, to progress to cancer. Now, probably not all adenomas actually become cancers. We know that the smaller polyps, what we call tubular adenomas, probably don't have much of a malignant potential, but when we talk about advanced adenomas, that is lesions over a centimeter in size, those with high-grade dysplasia or those with villous content, these ones are most likely to progress to cancer. These polyps undergo progressive dysplastic changes till they become an invasive colorectal cancer. There's also another pathway that probably leads to cancer, though probably not as commonly, and we call this the serrated adenoma pathway. In recent years, it's just been realized that this is probably another pathway that accounts for a significant number of cancers, particularly in the right colon. Many believe that these polyps actually undergo a faster progression to cancer, and this includes sessile serrated adenomas or polyps and traditional serrated adenomas. So what's the evidence for using fecal occult blood testing for colorectal cancer screening? Well, there was 3 major trials done back in the late 1990s, one in Minnesota, another in Funen, Denmark, and another in Nottingham, England. And these spanned close to 20 years in some circumstances. And they looked at the mortality reduction with annual or screening every 2 years, biannual screening. And it was quite significant. In the largest study, the Minnesota trial, with annual screening, there was a 33% mortality reduction. A Cochrane review in 2007 reviewed all the literature in regards to major randomized controlled trials for fecal occult blood, and they included those 3 trials plus another one in Sweden. Overall, there was a 16% mortality reduction overall. If you just did biennial screening, that is every 2 years, it was 15%. And if you looked at the mortality reduction adjusted for attendance, because the other ones were intention to treat, was a 25% mortality reduction. So if you show up for screening, you likely will experience a 25% mortality reduction across that population. What are the benefits of screening? How does it work, in other words? Well, first of all, we're after a mortality reduction. So we believe this occurs by the virtue of the fact that when we do screening with FOBT, we detect cancers at an earlier stage than we would normally. So many people will present with late stage cancers, stage 3, stage 4, where the chances of cure is much less. We want to diagnose people at stage 0, stage 1, when treatment is simple, sometimes as simple as removing a polyp, very often with surgery, which is the primary treatment, less likely to need radiation or advanced treatment such as chemotherapy. There's also a cancer prevention aspect of screening too. If we can detect early premalignant lesions, such as villous lesions or highly dysplastic lesions, before they become invasive cancers, we can actually prevent cancers. So the original study done with this is in 1993 in the New England Journal of Medicine. It was only a 6-year follow-up, but they found that people who had undergone colonoscopy, had polyps removed, had a reduced incidence of cancer in that population of 76 to 90% compared to the control population, which never underwent colonoscopy. So this was very exciting news. This is how we prevent cancer. When we find large advanced adenomas like this one here, which is a large polyp, likely a villous lesion, basically it's a simple matter of putting a snare around it, cauterizing it, and taking it out. Now, not all polyps are that easy to remove, but many are. A follow-up from that national polyp study looked at the risk of death after having a polypectomy, and it looked at it both in adenoma patients, that is people that had significant polyps, and non-adenoma patients, okay, compared with the expected colorectal cancer mortality in the population. Of interest, there was a similar mortality in the future for people who had adenomas or those who didn't, suggesting that removing the adenomas put people back to an average risk in terms of death from colorectal cancer. Overall, there was a 53% mortality reduction when they compared this to the expected mortality in the population, people that weren't in the study itself. This is very significant. So what is the best test for colorectal cancer screening? Okay, well, we're talking mainly about fecal occult blood testing, of which there's 2 types. The Guaiac fecal occult blood test, which is what we use at ColonCheck Manitoba, and some of the newer fecal immunochemical tests or FIT tests. There's also colonoscopy, which has been touted for many years as probably the best screening test. We can talk about that. I would argue this is a diagnostic test for the most part. It certainly has the best accuracy. There's also both flexible sigmoidoscopy, of which there's one program in Canada, and that's Ontario. There's also older technologies such as air contrast barium enema. And then we have newer technologies such as CT colonography or virtual colonoscopy, if you like, and some serum tests or metabolomic tests that look for metabolites of tumors in the bloodstream, the common of this being septin-9. There's also DNA stool analysis, which is a newer technology. This looks for fragments of altered DNA in the stool. It's quite a cumbersome test. It actually has a pretty good accuracy in terms of diagnosis or sensitivity for cancer. It's often combined with a immunochemical FIT test to look for occult blood at the same time. So colonoscopy quickly, it's believed to be the gold standard. It's very sensitive for cancer. There's mortality reduction. However, no randomized controlled trials have been done to date with the fecal immunotest in average risk patients. There's an inferred benefit by the fact that you can get a stage shift and diagnose cancers early, and of course polypectomy for advanced adenomas, which I've talked about already. The proponents of colonoscopy, and there are many, even here in Canada where we have fecal occult blood testing programs, but a lot of places in the States still consider this the best single high accuracy screening test. If you have a normal colonoscopy, it's generally believed that the protective effect of that colonoscopy will last up to 10 years. It can, however, miss many flat adenomas. Okay, these are adenomas or polyps which are hard to see, and particularly in the right colon. And many of these are serrated, sessile serrated adenomas, which are very hard to detect sometimes, even with colonoscopy. The disadvantages, however, is a fairly high cost for a procedure. It's a resource-intensive screening test, and we are always battling with limited endoscopy resources throughout the province. There's patient discomfort, there's complications, potentially complications such as perforation or hemorrhage, which could result in death. We also don't know what the real world performance of this test is. Are people actually going to choose this test over a fecal occult blood test? So as an organized screening program, we're looking for a test that's going to be acceptable to the public, one that we're going to get a fairly high participation rate in. Flexible sigmoidoscopy is basically a limited colonoscopy. For the most part, this is an examination from the rectum all the way to the splenic flexure. If polyps are discovered along the way, then the patient will require a complete colonoscopy. It's technically easier to do. You can do it without sedation, although I don't think I'd like one. It's nurses and family practitioners, as well as physician's assistants, are often trained to do this rather than physicians, and it has about 1/4 the risk of a colonoscopy. The disadvantages, however, it requires similar resources to colonoscopy, and it's a less thorough exam. And of course, you have to repeat the procedure if you find any significant polyps in this latter half of the colon. There's a lot of good evidence to support flexible sigmoidoscopy, however. 3 case control studies suggested up to 60% mortality benefit, a reduction in colorectal cancer mortality in the reach of the scope, that is up to the splenic flexure, and overall 33% mortality reduction in cancer. Probably one of the best series done was in the Lancet by Akins in 2010. They did a one-time flex sig in people aged 55 to 64, no further testing after this. The intention to treat, the people in the study received a 23% reduction in incidence, a 31% reduction in mortality. If you showed up for the test, you had up to a 43% mortality reduction from cancer. So bottom line is a review done here by Dr. Tinmouth at Cancer Care Ontario, reviewed all the additional screening tests that are available out there. They concluded that there's no evidence to support the use of CT colonography for average risk screening. We do use this as a follow-up test sometimes for colonoscopy when there's an incomplete exam or when people have a positive FOBT and they refuse colonoscopy. Air contrast enema is, as far as I'm concerned, is an outdated test. There's not many places that can even do it properly. DNA stool analysis, as I mentioned, is very expensive. It is not a particularly specific test. That is, it has a very high false positive rate. And again, septin 9 or fecal M2PK don't offer any benefit over FOBT testing. So we are what you would call a organized screening program. Okay, we're a population-based screening program. And what's the difference between us and a family practitioner or a nurse practitioner ordering a fecal occult blood test? Well, we feel that there is a lot of benefit to including the population within our program. We identify people in the population that are appropriate for screening. We screen a population of 50 to 74 years of age. This is the group of people which are most likely to benefit from screening. We try not to include people that won't benefit from screening. This helps avoid unnecessary screening procedures. We have measures within the program to guarantee a high coverage and attendance in our program. So we reach out to all areas of Manitoba to try and keep our recruitment equal within the different regions. We try to present an acceptable test, which we believe is the fecal occult blood test. And we also arrange for recall screening, which is important. When people have a negative test, we need to recall them in 2 years' time. We also provide resources for the public and professionals and assure adequate facilities and resources to carry on with our screening. Our data is compiled in a information system, which allows us to look at quality controls, give reports back, and provide feedback to providers and participants. So in other words, in order to have an effective population screening benefit, it's not just the test sensitivity, okay, it's also the participation, right? And this, of course, is the best way to get overall a good cancer detection rate within the population. So if we look at fecal occult blood testing, and this includes both Guaiac and immunotests, the actual test itself depends on the ability to detect blood loss. We believe that cancers bleed more than advanced adenomas or simple polyps. So you're most likely to detect advanced lesions. We know that you get increased detection with multiple samples if you keep repeating the test, if you do it more frequently, every year versus every 2 years, and if you have a lower threshold for sensitivity of blood within the feces. Okay. Most of the tests that we use here, a Guaiac test is 300 micrograms per gram. With some of the newer fecal immunotests, we can get down as low as 50 or even 20 micrograms per gram of feces. We do know, however, that when we have increased sensitivity, we have decreased specificity. Okay, we're more likely to detect false positives, and this results in more false positives and more colonoscopies. And again, I'd just like to reiterate, all positives require colonoscopy. If a patient has a positive test, don't repeat the test, because colon cancers or large polyps bleed intermittently. You may pick it up one time and not pick it up the other. Any test requires a colonoscopy. I'd like to point out, too, that the positive predictive value of a colonoscopy, if you have a positive FOBT, is about 5 to 6% for colorectal cancer. So you have about a 1 in 20 chance of having cancer if you have a positive FOBT. So what kind of polyps and lesions are we looking for? Apart from cancers, we're looking for conventional or adenomatous polyps. This includes tubular, tubulovillous, and villous. We're looking for serrated adenomas, sessile serrated adenomas, traditional serrated adenomas. There are also other types of polyps. Hyperplastic polyps are common, and true ones are not any risk for malignancy. We have hamartomas, inflammatory, and lymphoid polyps. And all these polyps have different morphologies. When you actually look at them in the colon, you really can't tell from the appearance what kind of a polyp it is. Having said that, there are certain familiar appearances of some polyps that suggest it's more likely to be one than the other. So we can divide our adenomas into low-risk adenomas, which I'm sure you've seen all the pathology reports, tubular adenomas less than 10 millimeters with no high-grade dysplasia. These lesions are unlikely to progress to cancer. High-risk adenomas, however, situations 3 or more of these adenomas, even the simple low-risk ones here, any adenoma with villous histology, that's tubulovillous and villous, or adenomas with high-grade dysplasia, we believe that these are the high-risk ones which can progress to cancer. And then we have sessile serrated adenomas. If you see a report saying sessile serrated polyp, okay, this should be assumed to be the same as a sessile serrated adenoma. Sometimes pathologists will use this term when they can't truly distinguish between it, whether it's an adenoma or perhaps a hyperplastic polyp in the right colon, and then traditional serrated adenomas. Overall, these serrated adenomas, excuse me for 1 minute. Okay, so this is a typical tubular adenoma. When we see these, we're pretty sure this is not a cancer. This is a nice smooth polyp. It's small. It's a very simple polyp to remove with a snare. When we talk about high-risk adenomas, again, we're talking about numbers 2 or greater, larger adenomas and villous content or high-grade dysplasia. This is a fairly typical appearance for a large villous adenoma. And you can see also here, there's also suspicion this might be a malignant tumor. This takes up about 50% of the circumference of the bowel wall. This kind of villous adenoma is usually quite difficult to remove and may even require surgery to safely remove it. Hyperplastic polyps are common. It's a type of serrated polyp, but a true hyperplastic polyp has no risk of malignant transformation. Proximal polyps, that is those in the transverse colon or in the ascending colon, may be difficult to distinguish from serrated adenomas, and sometimes you have to speak to the pathologist, or if they can't tell the difference, you treat them as serrated adenomas and have ongoing surveillance. There's also serrated polyposis syndrome, in which individuals get large numbers of serrated polyps throughout the colon. This includes the benign hyperplastic polyps. These individuals have a higher risk for malignancy. This tends to be inherited as an autosomal dominant disease. So what tests do we use at ColonCheck? We use Hemoccult to SENSA. This is a Guaiac test. We take 3 samples. The results are qualitative and use a peroxidase reaction. This is a non-specific kind of a reaction. The results are affected by diet. If you ingest a large amount of meat that's fairly raw, drugs, anything that makes you bleed from the upper GI tract, such as NSAIDs, and vitamin C can produce actually false negatives. So the initial results from this test showed that it had a fairly high sensitivity for cancer of 85% and was fairly specific. That is, it was good at excluding false positive. It had about a 5.6% positive predictive value for cancer, 26% when we say for tumor. That includes cancers plus advanced adenomas. The fecal immunotest are the newer tests. The advantages are that only one sample is needed. Results are quantitative, so we actually get a number that actually tells us the amount of blood which is in the effluent or in the stool. There's no reaction with upper GI blood. It's not affected by NSAIDs, ASA, or vitamin C. This is because this is any protein that's ingested in the form of hemoglobin is digested along the way, so this only detects colonic blood. The other good thing about this kind of a test is we can adjust the sensitivity or create a cutoff to alter the number of positives. So we can detect levels like 20 nanograms versus 300 nanograms. We know we have a higher sensitivity for cancer. If we're concerned about the number of positives in terms of colonoscopy performance, that is the cases we have to verify with colonoscopy, we can set our cutoff at a higher level. A large number of studies have shown that there's a much higher compliance using the fecal immunotest because it's a simpler test to use. This study here in gut in 2010 showed a participation rate of 61.5% versus 49.5%. So overall, if you compare the two, the Guaiac test that we use now is inexpensive. The FIT is more expensive. There tends to be better compliance. There's no interference with ingested blood in a FIT test. It doesn't detect upper GI blood. It's not affected by drugs such as NSAIDs or vitamin C, and we get a quantitative number, and this allows us to control our positive cutoff rate. And it has much improved sensitivity, not only for cancers, but also for advanced adenomas, which are the cancer precursors. So we did do a trial of FIT at ColonCheck, Manitoba, here back in 2015. We had this is our FIT test group. We were using OC Sensor, which is an automated FIT test, and our SENSA, which is our own Guaiac test that we use all the time. We had about the same level of participation here, overall about 45%. Interestingly, we thought we'd have a much higher positivity rate with a FIT because the sensitivity is 100 nanograms per ml, and our own test is about 300 nanograms per ml. But actually, the positivities were about the same. And this also suggests that because the FIT test only tests for human globin, that it's actually probably more specific in other ways, even though the sensitivity is increased. We're only detecting human blood. In that trial, about 90% of the people had follow-up colonoscopy. The results are not significant due to the numbers, but we had a adenoma detected in 66% of the FIT people, as opposed to only 38 in our SENSA people here. They also had a colon cancer detection rate of 2.9 cancers per 1,000 participants, which is extremely good in the FIT individuals versus only 0.7 cancers detected per 1,000 individuals. And when we surveyed the patients, 87% of the participants said that they would like to use the FIT over an FOBT. So what's the evidence for FIT? Well, here's a study done in 2010, Hemoccult 2, which is a Guaiac test, versus OC Sensor, which is a FIT. Positivity rate was much higher in the OC Sensor, but the sensitivity for cancers was greater in the OC Sensor or FIT test. It also diagnosed twice as many advanced adenomas and hopefully prevented cancer in those individuals. Another study done in 2012, this was a meta-analysis that looked at several studies. They included that the immunochemical test FIT was superior to Guaiac, both in regards to adherence, which is actually participation, and it was also better for detection of advanced neoplasia. You were 2.8 times as likely to pick up advanced adenomas with the FIT test. Also, the cancer detection rate was about twice that Guaiac test. You don't mind doing twice as many colonoscopies with a FIT test if you're finding 2 times as many cancers. Another study done in 2017. This is the National Health Services compared to FIT testing, which was OC sensor with a Guaiac FOBT. FIT uptake was higher with the OC sensor, the FIT test. Also interesting is people that didn't previously participate with the Guaiac test, 2 times as many of those improved their participation in the study. There was a higher positivity rate with the FIT test at a much higher sensitivity. However, the detection rate for cancers was about twice that for the Guaiac test. This is also a very interesting study done in Germany here, and this speaks to the concerns that people have about FIT having a higher positivity rate and this have a greater burden on colonoscopy. When they adjusted the sensitivity of these 3 FIT tests to match that of the Guaiac test, okay, the same positivity rate, which was about 5%, they found that even with that, even if you're getting the same number of positives, you're detecting almost twice as many cancers with the FIT test as you do with the Guaiac. And overall, the specificity was about the same. So if you look at overall, this is a compilation of many studies in the Annals of Internal Medicine looking at FIT sensitivity. One of the things to keep in mind is how they actually report the cutoff value here. You'll either see micrograms per gram or nanograms per milliliter, depending on whether it's measured in the stool or in the effluent in the test. If you look at only the colonoscopy cases here, and what they did is here, they took all participants, they gave them a test, and then they colonoscoped them afterwards, okay? And in those cases, they were able to get a true sensitivity for the test in terms of its cancer detection. You'll notice that the cancer sensitivity varies greatly depending on the cutoff value or the sensitivity of the test itself. But overall, if they looked at the colonoscopy group only, where they actually verified that they did or didn't have cancer, the sensitivity overall was 77% for cancer. Also interesting, if you look at multiple rounds of FIT testing, and this is what happens in the real world. So it's not just a one-time value of a test compared with colonoscopy, for example. It's the ability of that test to detect cancers as over multiple rounds of screening. What they've shown is, for the most part, when you have multiple rounds of screening, participation stays about the same. The positivity rate tends to stay about the same or drop a little bit. The positive predictive value for cancer falls with multiple rounds. And this is because in the earlier rounds of screening, you basically cull out all the prevalent cancers within the population. However, of interesting note, they still tend to keep picking up advanced adenomas, suggesting that within that population, there are polyps which are growing, there are polyps which are progressing. So this was another study done here looking at cancer mortality and FIT testing. This was a Spanish study. They looked at paired 2 groups, early stage screening and late stage screening. Overall, the mortality group was 23% lower for cancer in the early stage screening group than the late stage screening group where the screening had not yet started. So what about colonoscopy versus FIT? Many people still, as I said, might think this is the true test. We generally compare colorectal cancer and advanced adenoma detection. However, the true measure is actually mortality reduction. Okay, this is really the bottom line. Whether you detect cancers, are you detecting them early, or are you detecting them at the stage they're treatable? There's 3 ongoing randomized trials right now. The results will probably be available in 2021. And as I mentioned, you need to consider the results, not just a single test comparison, but also look at the results of repeated FIT testing. You have to consider compliance and participation. There's no point offering a test if people aren't going to participate. As well, the costs and risks of colonoscopy, cost to the system, risk to the patient. This is a good study done, a 10-year study looking at repeated rounds of FIT testing every 2 years in participants aged 50 to 69 years of age. The test is OC Hamidia. The cancer detection rate was high, as I mentioned before, in round 1. 1 to 3.3 per thousand for cancer, and this falls after round 3 to 1 in 1,000 because the cancers are culled out. However, for the most part, the advanced adenoma detection rate tends to stay about the same. These results, however, are very similar to colonoscopy studies, which have been done before. So we're hoping that FIT testing will show the same ability as colonoscopy to reduce mortality. This was a very good study done in Ontario. This is Baxter, Annals of Internal Medicine. This looked at over 100,000 people in Ontario that had colonoscopy. And this study is often touted as a study which really shows how bad colonoscopy can be. In these individuals, they followed the individuals who had colonoscopy, and then they looked at the estimation or the odds ratio of these people getting colorectal cancer. And they looked at cancers, all cancers in the colon, left-sided cancers and right-sided cancers. And it's very interesting that your odds of getting a right-sided cancer are really no better after colonoscopy. 0.99 is basically equal to 1. There was overall a protective effect for all cancers, which resulted in about a 37% reduction in mortality. So there was some benefit, but this speaks to the way that colonoscopy is done. Probably people are probably being done with questionable bowel preparation. There are flat lesions such as serrated adenomas that are hard to see. Some people think they're at the cecum. They think they've done a complete exam. They haven't. And also there may be tumors in the right colon, such as serrated adenomas, that are growing quicker than normal polyps. This is a picture I like. This is a picture of a sessile serrated adenoma on a fold of colon here. You can see this would be very easy to miss this. And this is the appearance you see sometimes in the right colon. This is the same one stained with methylene blue using a technique called chromoendoscopy, where we basically spray dye onto the wall. And once you see this, you'll see the typical mucus cap of a serrated adenoma along with the irregular mucosal pattern. So another very good study. This is part of the randomized control trials done for colonoscopy. This was a randomized study comparing the two. Very interesting. They detected equal number of cancers in each group. Okay, that's 1 per thousand basically. There was greater participation in the FIT group. As expected and has been found before, there are more advanced adenomas in the colonoscopy group. But however, the number needed to scope to find one cancer and was 191 in the colonoscopy group versus only 18 in the FIT group. This implies a much more efficient use of resources. So this is very encouraging. We'll have to wait for the final data in 2021. But basically, this says that FIT is at least as good as colonoscopy for detecting cancers. So we talked about average risk screening. I'll just talk a little bit about above average risk screening and some possible benefits even in surveillance of prior adenomas using FIT. This is a meta-analysis done at 12 studies with over 6,000 patients. This was in individuals who had a family history of colorectal cancer, okay? And overall, there was still an extremely good sensitivity for colorectal cancer using FIT and pretty good sensitivity for advanced adenoma. And this just speaks to the fact that our usual recommendation in people with a family history is to do colonoscopy. And I think that more work needs to be done in this. It's not going to make us alter our recommendations at this time. This was done by Catherine Dubé of Cancer Care Ontario. They did a meta-analysis of 8 cohort studies, 6 prospective, 2 retrospective. They looked at a sample size up to 4,400 participants and a follow-up of 4 to 10 years with good evidence. And this is very interesting because they looked at the rates of advanced adenomas, which are the precancerous lesions, is what we're screening for in the future when we do repeat colonoscopies. In the normal colonoscopy group, it's 3.3%. Low-risk adenomas, 4.9%, which is really not really any different at all. If you've had previous high-risk adenomas, however, there's a very high incidence of getting further high-risk adenomas and advanced adenomas. There's 2 studies here, one in Germany and one in France, okay? Looked at the rates of cancer and low-risk adenomas patients versus the general population. Basically, what they found was there's a significant decreased risk of cancer in people with low-risk adenomas. And this is probably because these individuals have already been cleared of any cancer, but it's quite interesting that your actual chance of getting cancer, these are odds ratios, are anywhere from 40% to 80% of the population in this study, or here 68% of what the normal general population would get. This was another study in the New England Journal of Medicine that again looked at the colorectal cancer mortality in people with low-risk adenomas, those small tubular adenomas, versus the general population. And again, there was a lower risk of getting dying from cancer in low-risk adenomas versus the actual general population who hadn't been scoped. High-risk adenomas, however, there was a higher risk of colorectal cancer mortality. So basically, there's a lower risk of cancer and mortality with low-risk adenomas, these 1 to 2 tubular adenomas, and a small increase in relative risk for high-risk adenomas compared with a normal colonoscopy. And because of this, some individuals, such as Cancer Care Ontario, are recommending that rather than doing 5-year post colonoscopies in these individuals, they should just be screened with FIT. Just very briefly now, our results looking across Canada here at some of the other provinces. Saskatchewan, they use Polymedco, which is OC sensor. They have a lower cutoff of 100 nanograms. Ours is about 300 here. Alberta has 75. They tend to have higher positivity rates than we get within our program using Guaiac. They have a much higher positive predictive value for cancer and adenomas. And similarly in Quebec, which uses even a higher cutoff, they tend to have a slightly lower positivity rate, though they claim they have a positive predictive value of cancers and adenomas of almost 100%. I find that a little hard to believe. So you'll see across Canada, most of the other programs are switching to FIT. So in conclusion then, the evidence generally shows that FIT is superior to a Guaiac FOBT for the detection of advanced adenomas and colorectal cancer. Screening participation with FIT is generally higher than with Guaiac FOBT. FIT is as likely or effective as colonoscopy in detecting CRC or colorectal cancer, probably not for advanced adenomas. And in the future, FIT may provide opportunities for screening high-risk populations. And again, may also provide opportunities for providing future surveillance in some circumstances that are believed to be at low risk of progressing to cancer at a later date. I truly believe that in Manitoba here, we need to replace our current Guaiac FOBT Hemoccult SENSA with an automated FIT screening tool. Thank you very much. Just wait for 1 minute. Leslie Baldry is going to continue the talk.
Thank you, Ross. All right, so I'm just going to go over what ColonCheck does to support Manitobans in colorectal cancer screening. So based on our current evidence, ColonCheck develops and distributes comprehensive colorectal cancer screening guidelines and surveillance recommendations. In September of 2018, the Canadian Association of Gastroenterology, or CAG, published revised guidelines for colorectal cancer screening. In turn, we've revised our guidelines to reflect the evidence shared in the CAG guidelines. So when determining the appropriate colorectal cancer screening test for your patients, it's important to first understand the risk for your patient in developing the disease. In determining risk, consider the age of your patient. So screening program currently targets men and women 50 to 74 years of age, but what is the recommendation for persons outside of that age group? Is there a family history of colorectal cancer or high-risk adenomas? If yes, who and how many? And what was the age of diagnosis? Is there a personal history of colorectal cancer, colitis, or genetic syndrome such as Lynch syndrome? Is the patient experiencing symptoms such as persistent changes in bowel habits, anemia, or abdominal pain? People are considered at average risk if they have no personal history of colorectal cancer or precancerous polyps, Crohn's disease, ulcerative colitis, inflammatory bowel disease, and they have no first-degree relative family history of colorectal cancer. So at this time, average risk persons should do an FOBT test once every 2 years. starting at the age of 50. Those at increased risk of colorectal cancer include individuals with a family history of one or more first-degree relatives with colorectal cancer or advanced adenomas. Evidence shared in the CAG guidelines supports that second-degree family history diagnosis of colorectal cancer or advanced adenomas are not at an increased risk for colorectal cancer. The preferred screening test for individuals at increased risk is colonoscopy. For patients with one first-degree relative diagnosed with colorectal cancer at any age, the recommendation is colonoscopy every 5 to 10 years starting at age 40 or 10 years earlier than the youngest relative's diagnosis. FOBT every 1 to 2 years may be an alternative for this category. For patients with one or more first-degree relative diagnosed with advanced adenomas, the recommendation is colonoscopy every 5 to 10 years or FOBT every 1 to 2 years starting at the age of 40 or 10 years earlier than the youngest relative's diagnosis. For patients with 2 or more first-degree relatives diagnosed with colorectal cancer at any age, the recommendation is colonoscopy every 5 years starting at the age of 40 or 10 years earlier than the youngest relative's diagnosis, and FOBT is not recommended as an alternative for this category. Personal history of the following will also increase a person's risk of colorectal cancer. Previous diagnosis of colorectal cancer or adenomas requiring surveillance, confirmed or suspected hereditary syndromes such as Lynch or familial adenomatous polyposis or FAP. Inflammatory bowel disease with associated colitis, Crohn's disease, or ulcerative colitis. For these patients, the recommendation is surveillance and management as per the endoscopist. For more information can be found on the Cancer Care Manitoba website under the colorectal cancer patient follow-up treatment summary and follow-up schedule. And this is where you can find it on the Cancer Care website. Also at possible risk for colorectal cancer are those who have symptoms of colorectal cancer. Symptomatic patients at any age who have persistent rectal bleeding, change in bowel habits, and/or abdominal pain, iron deficient anemia, palpable mass, these folks need urgent referral to endoscopy for investigation. Currently in Manitoba, approximately 50% of the eligible Manitobans are up to date with their colorectal cancer screening. Being eligible is defined as not having an FOBT in the last 2 years, colonoscopy or flex sig in the last 5, and no personal history of colorectal cancer. ColonCheck's program initiatives include managing FOBT screening activities, maintaining colorectal cancer database registry, developing colorectal cancer screening guidelines, and creating provider and public resources and educational opportunities such as these. ColonCheck also mails FOBT kits to eligible Manitobans 50 to 74 years of age, and we manage abnormal and normal test results, as well as mail FOBT recall to eligible Manitobans every 2 years. Ways to access the ColonCheck FOBT kit include: our hope is that a client will respond to our initial invite that comes in the mail. However, if that does not happen, Manitobans can also request one at getcheckedmanitoba.ca or our new website, cancercare.mb.ca/screening, or by phone at 1-855-95-CHECK. For clients unlikely to request their own kit, healthcare providers can request a kit with the permission of their client using the FOBT request form. When a client has abnormal test results, ColonCheck contacts the client directly by phoning and advising them of their positive test result. Then a result letter is sent both to the client and the healthcare provider. ColonCheck then initiates the referral for colonoscopy. Clients within the WRHA will also be invited to participate in a pre-procedure appointment with our nurse practitioner. Quality checks for our program include and are not limited to communicating test results to clients within 3 days, ensuring colonoscopy referrals are processed. We have a database registry which helps us to monitor the status of colorectal cancer in the province, regular client surveys, and annual endoscopist report cards. It's important to note that the recommendation by you as physicians and healthcare providers is very important. When we did a survey a while back, Reasons cited for not completing an FOBT, the two highest ones, 19% did not think it was necessary, and 75% of people who responded said that their doctor did not recommend doing an FOBT. So your recommendation does count. So we're going to take some questions at this time. And if you could tap them into the chat box, that would be appreciated. And I'm going to let Ross probably answer most of the questions at this point. So, and you can unmute yourself. You push Control M on your laptop or your computer. All right. Are there any questions? We can't hear anybody. I guess if you can unmute yourself, that would be great. I'm just going to go through and unmute everybody in case there's questions. Oh my God. If you don't want to be unmuted, then you can just mute yourself back. That's fine. Yeah. All right, any questions from anybody? So it was a very nice presentation. No questions. Okay. Thank you, Kamal. Anyone else have any other questions at all? We've got about 10, 15 minutes.
So you're saying, okay. There's a question asked about if the healthcare provider checks FOBT, does ColonCheck get the result? No, we don't. If you provide a test that's not supplied by the program through Dynacare or some other private lab, or even through DSM lab in the rural areas, we do not get that result. It's actually an interesting question because we do feel it would be useful if we did have an opportunity to manage all the results, basically FOBT province-wide. And this gets back to the idea of programmatic screening, but we do not get those results. In those circumstances, it's really up to the primary care provider to provide the follow-up for that in respect of whatever that result is.
Why would population think that the test is not necessary? I would think that we need to.
So the question is, why does the population think that the test is not necessary? I would think that we need more to do in promoting the test. I think you're right. I think that population and from a client's or patient's point of view, they don't entirely understand all the time the concepts of screening, and that they're feeling fine. They don't have any symptoms. And so they think they don't need to do it. And we try to communicate to the population that this is a test that's exactly designed for that, for people that do not have any symptoms at all. Okay, we know perforation rate for colonoscopy is done through ColonCheck. Scopes done for positive FOBT. I can't give the exact rate. I am aware of 2 perforations over the course of the program. It's over going on 11, 12 years or so that occurred early on in the program. Okay, very good question. What's the reason for Manitoba not switching to FIT testing? We ask this question all the time ourselves. We do feel that it is, I think, is a must to switch to FIT. We were, for information, the first programmatic or provincial screening program in Canada. We are now perhaps the last program to actually adopt FIT. We feel it's a much better test. We're concerned about our lower rate of cancer detection with our Guaiac test and not detecting advanced adenomas. Cost is a big factor in terms of this FIT test, not so much the test itself, but the analysis is more expensive. We're actually looking at the big benefits. So downstream, we expect that we could probably save more lives with FIT. We also think that this would be a cost saving to the system in terms of early stage cancer detection and hopefully the ability to negate, adjuvant treatments for colorectal cancer such as radiation therapy or chemotherapy. And as well as that, detecting people in early stage simplifies surgery, gets people back to work quicker. So we're looking at this right now, but I think there's pretty good evidence out there. I didn't really get into it today. There's pretty good evidence to show that good high sensitive tests are a benefit not just to the patient but also from an economic point of view. Very good. Someone makes a comment. I work in primary care and feel like I am trying to convince patients to do their testing. Such an easy screen compared to cancer treatment. Very true. Another question, can you tell us about the staining for flat polyps in the right colon and retroflexion? Well, certainly, as a general rule, a lot of endoscopists don't use chromoendoscopy for doing when they do colonoscopy. It is used fairly commonly when doing surveillance for really high risk situations such as people with chronic ulcerative colitis. In fact, it's probably the standard. I certainly think it's something that should be used in patients that have had a lot of polyps or where you're looking at areas of the colon. It's hard to tell whether it's a polyp or not. Retroflexion is important in the colon, retroflexion in the rectum, and as well, some individuals perform retroflexion in the cecum, but certainly retroflexion is important. Here's another question, would it make more sense then for us as providers to just order the FIT testing until it becomes part of the program? I understand what you're asking. You can get it through other providers at the present time. I don't know what test they're providing, so I can't tell you if it's much more sensitive than the test that they're using right now. I think if someone is insistent on it and they don't want to do our Guaiac test, then I say, well, they have to pay for it, but it's better than doing no screening at all. It gets sent out of province for processing. That's right, too. And again, we don't get that information. Yeah. Any other questions? Thank you very much, and thank you very much for the good questions. Very challenging, some of them. Thank you. Thanks again. Please feel free to contact us or call me directly at ColonCheck if you want to ask anything about screening or the various tests that we use for screening. I'd be happy to call you back. In fact, please call me because I don't get that many calls. Okay, thank you.